all for joining us for our second Arizona Antimicrobial Stewardship Office Hours. Today's presenter is Dr. Neil Ample, and he'll be discussing asymptomatic bacteriuria and diagnostic stewardship. Before we get going, I want to ask that everyone please remain on mute during the meeting. If you have any questions that come up, please feel free to type them in the chat throughout. Otherwise, we ask that you remain on mute until we reach the discussion and Q&A portion of today's session. And once again, we encourage audience engagement at that time. So with no further ado, I would like to introduce Dr. Ample, who's a consultant within the Arizona Department of Health Services, as well as an Emeritus Professor of Medicine and Immunobiology at the University of Arizona, and a supplemental consultant in infectious diseases at the Mayo Clinic in Arizona. His interests include coccidioidomycosis, HIV management, and diagnostic stewardship as it pertains to infection prevention and antimicrobial stewardship. He is the former chair of Infection Control Committee at the Southern Arizona Veterans Affairs Medical Center and has established the Antimicrobial Stewardship Committee there. He is a graduate of the University of Oregon School of Medicine, which is now known as the Oregon Health and Sciences University, and completed a fellowship in infectious diseases at Brown University affiliated hospitals, as well as a research fellowship at the University of Pittsburgh. So with no further ado, I will hand it over to Dr. Ample to begin his session. Thank you so much for presenting with us today.
Thank you, Kelly. We'll get going here. I think we just started. We're going to begin today. We're going to talk about asymptomatic bacteriuria, and we're going to ask some questions for background. And the first one is asymptomatic bacteriuria is defined as a urine sample with a positive gram stain, greater than 10 to the fifth colony-forming units per mil of a single uropathogen in a urine culture in an asymptomatic patient. Dysuria with pyuria, greater than 5 cells per high-powered field on urinalysis, or none of the above. So we'll wait a moment. I'll wait for Kelly or Toe. Kelly, you're running the poll, correct?
That is correct. I just shared the results for this first question.
Okay.
Are you able to see those?
Yeah.
Perfect.
And let's see if my slides change. And so the answer is greater than 10 to the fifth colony-forming units per mil of a single pathogen. I'm trying to move this out of my way. So now we'll go to the next question. It's appropriate under which circumstances to obtain a urine culture? On hospital admission, during emergency room evaluation for sore throat, during pregnancy, and prior to joint replacement surgery. So if that's about it, so we have sort of a mixed result there, but let's go to the answer. It's during pregnancy. I'm glad that no one answered joint replacement surgery, but we'll come back to why it's not appropriate on hospital admission. Okay. The next question is, which of the following are true for most patients? An abnormal urinalysis has a high specificity for predicting a urinary tract infection. A clinical history and examination is indicated before obtaining a urine culture. A urine culture should always be obtained when there's a change in mental status, and it's appropriate to obtain a urine sample from the drainage bag of a catheterized patient.
Ken, do you mind if I play this? Oh, do you mind if I play it all up?
Oh, yeah.
And someone is unmuted, just so you know. Okay. So I think we've got those results. And the answer here is a clinical history and examination is always indicated before obtaining. And we'll discuss the other issues that people answered positively on. The next one is diagnostic stewardship can be defined as making sure there's a clear diagnosis before starting antibiotics, requesting an infectious diseases consult to advise on antimicrobial therapy, ordering the right tests for the right patient at the right time, and isn't required if there's already antimicrobial stewardship program. And I think we probably got it, and most people got the answer that I would have given, which is ordering the right test for the right patient at the right time. The next question is the steps of diagnostic stewardship. A, do not require any input from the clinical laboratory. B, intervention may occur at ordering, collecting, testing, and/or reporting. Accepts that a clinician may order any test offered by the electronic health record. And finally, D, requires laboratories to report all testing results. And I think people did pretty well on this one, where the answer is intervention may occur at ordering, collecting, testing, and reporting. Okay, so hopefully if I can get rid of these poll results, good. So now we're going to begin the lecture. And in clinical medicine, there's a huge problem where we rely overwhelmingly on laboratory diagnoses. It's kind of how humans are made, that a laboratory test is often given more weight than clinical diagnosis. But that can become a real problem. Almost all laboratory tests require interpretation and must be correlated with clinical symptoms and signs. And in addition to that, there always has to be an understanding of the sensitivity and specificity of the test as it relates to disease. If not, inappropriate reliance on laboratory testing leads to a lot of adverse outcomes. It increases inappropriate testing and increases costs. It leads to unnecessary treatments and increased adverse outcomes. And asymptomatic bacteriuria, ASB, exemplifies all of these about inappropriate laboratory testing. This is a coffee mug from my friend Dr. Lisa Spicer, who runs infection prevention at Mayo Clinic. And I think it's a very good image for us today, coming from the matrix. A positive urine culture is not a UTI. That's the red and the blue pill right there. And that's what we're going to talk about. So the first thing is, we're talking about asymptomatic bacteriuria. What is it? Well, it's a significant number of bacteria in the urine without symptoms. How is that defined? Well, it was defined by Dr. Edward Cass at Harvard University way back in the 1960s. And what Dr. Cass was interested in at that time was what defined a symptomatic urinary tract infection. So what he did is he studied pregnant women with symptomatic pyelonephritis. And when he collected urine samples on these women, what he found was he always got greater than 100,000 or 10 to the fifth colony-forming units of a coliform, usually E. coli. And if he repeated that urine, he got the same thing. That's where that number comes from. And as we'll talk about, that number is not absolute, and it is only applies to pregnant women with pyelonephritis, which is something we're not going to be talking about today. Since then, we have other rules greater than 10 to the 2 or 100 colony forming units per mil when we do a straight cath or a single non-indwelling urinary catheter sample. And in people with indwelling urinary catheters, Foley catheters, it goes back up to 10 to the 5th. But it's important to realize the finding of bacteriuria alone does not indicate the presence of infection. And what are the consequences of obtaining urinalyses and urine cultures on people who are asymptomatic? Well, first of all, it contributes up to 21% of laboratory overutilization. And in one study, that was over nearly $6,500 a month in laboratory costs alone, just from getting inappropriate urinalyses and urine cultures. It frequently leads to unnecessary antibiotics, as I'll show you in a bit, and it's associated with multiple adverse outcomes: increased antimicrobial resistance, both for the patient and the institution, increased risk for allergic and other complications, and increased risk for infections from other organisms, particularly Clostridioides difficile. And it's important to realize that this is a problem among patients as they age. So about 6% of premenopausal women have asymptomatic bacteriuria, but this goes up to 20% in healthy women up to 80 years, and it even occurs in men. So men over 60 have about a 19% rate of asymptomatic bacteriuria, and those risks go up with underlying comorbidities such as diabetes mellitus, impaired cognition, uh, neurologic or anatomic abnormalities that impair voiding, and indwelling catheters. So this problem of asymptomatic bacteria particularly impacts patients who are older and iller. And what is the outcome of treating asymptomatic bacteria? This is a nice study from the Michigan Hospital Medicine Safety Consortium, a very nice group out of the University of Michigan. So they studied 2,733 patients who got a positive urine culture but had no documented signs or symptoms. 83% of those individuals received antibiotics for a median of 7 days. And the factors associated with increased antibiotic treatment were all those comorbidities: older age, dementia, altered mental status, urinary incontinence, leukocytosis, an abnormal urinalysis, and of course a urine culture meeting the definition. And the only outcome that was found was a longer duration of hospitalization. So treating asymptomatic bacteria in general doesn't lead to a better outcome. So this leads us to when should we be ordering urinalyses and urine cultures to assess for your UTI? So the rule is we should only do that when there are signs and symptoms suggestive of a urinary tract infection. Again, going back to Dr. Cass's study, that's how he defined bacteriuria in people with symptoms. The second point is to realize if we use urinalysis as a screening tool for urine culture, it's not a very good screening tool. It only has, in general, about a 30% specificity for UTI, meaning in 70% of cases, it doesn't mean, if it's abnormal, patient may still not have a urinary tract infection. So you should never order a urine culture simply because the urinalysis is abnormal. Finally, a urine culture should only be interpreted if the urinalysis is abnormal and there are signs and symptoms consistent with a urinary tract infection. And neither a urinalysis or a urine culture should ever be ordered routinely. So what's the process for assessing for a urinary tract infection? So the first step is you have to assess the patient for signs and symptoms of a urinary tract infection. And in a non-catheterized patient, this is dysuria, suprapubic or flank pain, costovertebral angle tenderness on physical exam, fever and hypotension, which is sepsis, and fever or leukocytosis without any other explanation. In a catheterized patient, the rules are exactly the same, except you may consider change in mental status or delirium if there's no other explanation for that. So once you've done that, then it's reasonable to get a urine sample and interpret a urinalysis. And the first thing we have to go through is how do we do that? Because it's not very simple. So the first thing we're going to do in a non-catheterized patient, we're going to want to clean catch midstream urine. So the first thing is we have to cleanse that urethral opening. Then we have to void, the patient has to void the first portion of the urine, and then you have to collect the midstream, remove the container, replace the cap, and submit it. And it turns out it's quite different between men and women. It's much easier in men. For an uncircumcised male, retract the foreskin, clean the head of the penis, and then go ahead and do the midstream. For women, just the cleansing is far more difficult and requires at least 3 different wipes. So just getting a clean catch midstream has to be done correctly and requires a fair amount of work. The next thing is we've got our urinalysis. We need to interpret it. And if you look at a urinalysis, you have about 16 elements to interpret. We have appearance, chemistry, and microscopic examination. So let's go through. Appearance, we have color, turbidity, and odor. But if we look over to the right, all of those are really nonspecific for predicting a urinary tract infection. If we go to chemistry, of all the criteria, we're really only interested in leukocyte esterase and nitrites. Leukocyte esterase is a surrogate for pyuria. The presence of nitrites is a surrogate for bacteriuria. Not very specific. So finally, we get down to our microscopic exam, and we have two elements there. First, bacteria, very nonspecific as shown here. The real important one, white blood cells, or pyuria. Pyuria can be measured two different ways, depends on the lab, greater than 5 cells per high-powered field, or they may count greater than or equal to 10 cells per microliter. And pyuria is the most important predictor of a urinary tract infection. And just to show you this study on degree of pyuria, in patients who had just 10 cells per microliter in, in diagnosing urinary tract infection in older women, only about 3 in 20 with that had a UTI. But if you went up to 400 cells per microliter, here 19 out of 20 or 95%. So the degree of pyuria, not just the presence of it, is very important in predicting whether there's a UTI present. And here they had a cutoff of 264 white cells per microliter. The sensitivity and specificity were 88%. So it's presence of pyuria, but the more pyuria, the more likely a urinary tract infection is to be present. So now how do you interpret the results of a urine culture? You've gone ahead and gotten one. And the first is the results should be disregarded if the patient is without signs and symptoms attributable to urinary tract infection. You should never have gotten it. And if the urinalysis is not abnormal, and particularly if there's no pyuria. In those cases, you want to be very careful about interpreting the results of a urine culture. Now, here's where I have to sort of bring out where the 10 to the fifth rule is very specific and doesn't always help us. So as we said, Dr. Cass defined greater than the 10 to the fifth CFU per mil when a uropathogen are seen. So that was in the 60s. And in the 80s, Dr. Walter Stamm at University of Washington started saying, hold on a second, I'm seeing premenopausal women who have dysuria. They have symptoms. But when I get a urine culture, it's less than 10 to the fifth. And it turned out those women fell into two categories. They had fewer than 10 to the fifth of a coliform. That is, they had, say, an E. coli urinary tract infection. It just didn't meet Dr. Cass's criteria. Or they had a urinary tract infection from atypical organisms such as chlamydia, ureaplasma, mycoplasma. Now, we're going to not talk about this more, but it's just important to realize that these rules are just rules. You have to understand where they come from. So if you have a premenopausal woman who's symptomatic, she may have a urinary tract infection that requires therapy, even though you don't have 10 to the fifth. So what are the steps that we should undertake when we suspect a urinary tract infection? And the first is we have to have signs and symptoms, as we've talked about, dysuria, suprapubic or flank pain, fever with hypotension, etc. Then you get a urine sample, and then you ask the lab to do a urinalysis. If there's pyuria, then go on for urine culture. If there's no pyuria, you shouldn't get a urine culture. If you've gotten the urine culture and it grows out greater than 10 to the fifth, the patient's symptomatic, the urinalysis is abnormal, then you can move on and consider treatment for urinary tract infection. But if not, consider other things. And we've already mentioned the exception for symptomatic premenopausal women. When should you not do a routine urinalysis and urine culture? All these elements: hospital admission, emergency department visit, general preoperative evaluation, change in odor or appearance of the urine, and a clinical condition not associated with a urinary tract infection, such as change in mental status in a non-catheterized patient. We shouldn't be doing urinalyses and urine cultures to rule out UTI under these circumstances. What are the exceptions? Well, the first is pregnant women. So asymptomatic bacteriuria occurs from 2 to 7% of pregnant women. And without treatment, 25 to 30% will develop a symptomatic urinary tract infection, including pyelonephritis. If you treat that, the risk is reduced 70 to 80%. And pyelonephritis in pregnancy is associated with an increased rate of preterm birth and low birth weight. So it is recommended to obtain a urinalysis and a urine culture at least once in early pregnancy. In this case, it's midstream without clean catch. And the reason for that is operational. It's just very hard in a busy pregnancy clinic to be getting all that clean catch. And 10 to the fifth at least once, but preferably twice, and then you should treat. And you can see the treatments there. So pregnancy is an exception to this rule. We should be screening pregnant women and treating them. When else? Well, if you're going to do urologic surgery that breaches the mucosa. And what are the two procedures? Transurethral resection of the prostate and bladder biopsy. Not recommended for prostate biopsy. Those are transrectal and have different rules. And in those cases, if you find a significant bacteriuria, even if the patient's asymptomatic, you can give a single dose of an appropriate antibiotic 30 to 60 minutes before the procedure. But when should you not be doing this? Other surgical procedures, including orthopedic procedures, and after renal transplantation. So those are the two exceptions. Biopsy that breaches the bladder mucosa, and pregnancy. So now we're going to move on and talk about diagnostic stewardship and how we might use it to decrease both the diagnosis and the treatment of asymptomatic bacteriuria. So what is diagnostic stewardship? Well, the formal definition came about 2017. And so we can see two of these. It's modifying the process of ordering, performing, and reporting diagnostic tests to improve the treatment of infections and other conditions. Or, as we had in the pretest, ordering the right tests for the right patient at the right time. So diagnostic stewardship uses the diagnostic process to try to control for the overdiagnosis and overuse of antibiotics in a stepwise manner. It acknowledges, as we've already said, that laboratory tests alone are often not diagnostic, but frequently drive diagnostic decisions because of our psychological reliance upon them. So we know that laboratory results should always be combined with clinical criteria. And diagnostic stewardship tries to do that by intervening in the steps: ordering, collecting specimens, controlling the reporting back, and giving feedback to clinical staff. Now, ideal diagnostic stewardship interventions, as stated by Dan Diekema, have some characteristics. They should be built into the ordering, collecting, testing, reporting workflow. They should be minimally disruptive to the clinician, but not bypassable. And they should serve to educate clinicians while improving selection and interpretation of tests. So we can think of this as 3 phases and 5 steps. So the first step, of course, is the clinician thinking that a test needs to be ordered. And here the clinician needs to think of pretest probability and understand the test performances. And then that clinician will go ahead and order the test. And that's really the first part where diagnostic stewardship comes into play. That is at the electronic health record, because there it can list indications or decision support, provide nudges. Did you do a physical examination? Does the patient have a catheter? How did you collect this urine? So it's the first place where the clinician can interact with the ordering process to be modulated. The next step, if I can get it there, there we go, is specimen collection and transport. So a urine sample comes to the lab can ask, how was this urine collected? Was it from a catheterized patient? How did you obtain it? How long did it take? So they can stop the process there. The next one is test processing and performance. The laboratory could say, look, we have a urinalysis and it's normal. We're not going to go ahead and do a culture on this sample because this is normal. And finally, test reporting. Perhaps the result is less than 10 to the fifth. The laboratory would report that out, and it might also frame the results by saying, this is below the level of significant bacteriuria. Or it may say there were 3 or more organisms we're not going to test. So this is how these 5 steps and 3 phases, the laboratory and the EHR interact to help the clinician come to the best decision. So how does diagnostic stewardship differ from antimicrobial stewardship? Well, it's important to remember they develop differently. Antimicrobial stewardship probably began about 2008, 2009, and diagnostic stewardship was articulated much later in 2017. So they're very different processes. Diagnostic stewardship modifies the process and ordering of tests and occurs at the start of the diagnostic process, where antimicrobial stewardship modifies ordering of antimicrobials once the diagnostic process is started. So these are really complementary and non-exclusionary processes, and we can look at that here. Below is diagnostic stewardship, starting with the ordering of tests and going along as perhaps empiric antibiotics are started, more diagnostic tests and reporting, where stewardship comes in later once antibiotics are started and continues later if there's going to be antimicrobial modification. So you can see that these are complementary and non-exclusionary. So how might this work? Well, this is from Clinical Infectious Diseases in 2022 from Kimberly Clays and her colleagues, showing how you can apply some rules. So for example, if we have patients without urinary catheters, who should you be getting a urine analysis and urine culture on? Appropriately with these symptoms: uncertain fever or systemic leukocytosis, inappropriate altered mental status, or change in urine characteristics. Here with urinary pathogens, again, the appropriates are the same. A little more uncertain, we have fever, leukocytosis, and delirium without other cause. But still inappropriate is change in urine characteristics. Another way to look at it is looking at urine culture's best practices. The appropriate practice require documentation of signs and symptoms of a urinary tract infection. Conditional reflex urine cultures only when the urinalysis demonstrates inflammation, and that would be pyuria. And we didn't talk about this one, but don't have cultures just to repeat or repeat orders to repeat cultures on an ongoing basis. Inappropriate practices, don't have these as standards. Urinary room, emergency room, whoops, go back. Emergency room evaluation, hospital admissions, inpatient preoperative evaluations, assessment of altered mental status, assessment of falls. and don't respond to change in urine character. So these are some rules you can put in place to try to reduce the number of times you get a urinalysis and urine culture when the patient is asymptomatic. And here's a way to break it down into those diagnostic stewardship phases. Pre-analytic, limit testing to only those with signs and symptoms, require documentation of appropriate collection. Analytic, only culture urine samples that have inflammatory markers. Don't analyze further when you have more than 2 organisms. And post-analytic, here's where the lab can contextualize the report, indicate that high colony counts may occur when the patient is asymptomatic. Nudge providers not to treat asymptomatic bacteria or mixed growth. Clearly define whether an isolate is a uropathogen or not, like a staph epidermidis. Don't treat that. Limit antibiotic susceptibility reporting so that antibiotics are not there for the clinician to look at. Now, does this work? So in this study, again, from the Michigan Hospital Medicine Safety Consortium, they looked at over 4,000 patients with asymptomatic bacteria. That was 28% of all urine cultures. So 28% of all urine cultures in this cohort were inappropriately obtained. And as we've already said in this study, 78% received antibiotics for a median of 6 days, all inappropriate. So they said, well, let's look at our diagnostic stewardship metric. This would be how many asymptomatic bacteria did you get versus all urine cultures. And so if they saw a decrease in asymptomatic bacteria over time, that would indicate that diagnostic stewardship was working. For antimicrobial stewardship, they looked at everybody who got treated with asymptomatic bacteria versus treated and untreated. So did they see decreased treating in that group? So let's see what they found. What they found is for diagnostic stewardship, basically decreasing the rates of testing, they had a significant decrease over 2.5 years from 34% to about 23%. Not tremendous, but significant. For stewardship, they didn't reduce treatment per se significantly. They went from 82 to 77%, but they did decline the duration from 6 days to just under 6 days. So in both cases, some effect, but possibly a greater effect on stewardship, that is decreasing the number of inappropriate urine cultures versus treating. And it just tells you, once you get an inappropriate urine culture, that treatment sort of follows that. And so if we could stop the testing, we would probably stop a lot of inappropriate antimicrobial use. So what should the rules be for diagnostic stewardship and urinary tract infection? We should only order a urinalysis if there's symptoms and signs suggestive of a urinary tract infection. Urine cultures may be obtained with the urinalysis, but only processed if the urinalysis demonstrates an abnormality. And this is sort of accepting that you can't be getting 2 samples. So we understand that in any clinical situation, you would probably order a urinalysis and a urine culture on the same sample. But the laboratory should be able to distinguish those and not do a culture if the urinalysis is without inflammation. We got to make sure that samples are properly collected, either clean catch midstream or appropriately obtained from a catheterized patient by using the port and never the bag. And antibiotics should only be started when there has been a clinical examination, the urinalysis is abnormal, and the culture indicates a uropathogen, preferably at greater than 10 to the 5th. So what rules for appropriate management could be set? Well, we could have ordering strategies at the bedside. So prior to ordering, demand that that documentable symptoms and signs are present. And again, dysuria, suprapubic or flank pain, costovertebral angle tenderness, fever, and hypotension. Make sure that before you can order, that has been done. Or the patient is having the two exceptions, pregnant patients or patients having urologic surgery that disrupts the mucosal barrier, then it's fine. Alerts provide information discouraging urinalysis and urine cultures in asymptomatic patients. So it sort of slows the clinician down, and review the problem of overuse of antibiotics in these situations. The laboratory plays a huge role. The laboratory could stop processing a urine culture unless it sees there's documentation in the clinical record of symptoms and signs. There's documentation that the sample has been properly collected, and documentation that the urinalysis is abnormal. And then you can have reporting strategies, selective reporting, only report results for greater than or equal to 10 to the fifth colony forming units per mil of a uropathogen. Do not report mixed flora or organisms likely to be contaminants. And finally, provide education discouraging ordering of urinalyses and urine cultures in asymptomatic patients. Now, one of the good things about the Zoom meeting being canceled is I was thinking about this and I realized it's easy to say, oh, let's just institute diagnostic stewardship, but it's actually extremely difficult to implement. So let's go over some of that. This is very much like what happened, but shifted in time with antimicrobial stewardship. You need institutional buy-in. This is an institutional process that is multidisciplinary. If you don't have administrative support, support by your clinical staff, information technology support to work on the electronic health record, and laboratory buy-in, you can't move. And there are many, many resistance factors to trying to do this. A big one is loss or perception of loss of autonomy among clinical staff, because they feel, gee, you're taking my right to take care of the patient. And that's not a trivial issue. So that requires education and discussion. Then you have EHR modifications and assessment. Not easy to do. And even if you can get those modifications, again, you need buy-in, for example, from your hospitalist or from your ED to make sure that that modification you make doesn't have unintended consequences. So you not only need to get the buy-in to do the modifications, you need to assess that those modifications are doing what you want. Probably most importantly is the increased laboratory workload that diagnostic stewardship brings. Because as we've said, the laboratory needs to start screening samples, saying we're not going to accept this sample if it hasn't been properly collected or there's no documentation that the patient has signs and symptoms. That requires somebody to do that. The same with deciding if the urinalysis is abnormal, whether to go on in culture or not, and even modifying reports. So there's a marked increase in laboratory workload. And to date, there is a lack of reimbursement to do all this. And finally, there can be difficulty in measuring outcomes, as I showed you in that paper before. So you really need institutional buy-in before you can do this. And I will say, in my view, we're not quite there yet with an institution saying we should do this, where they will pay, for example, for FTE to really achieve this. But what you can do is start the process. And the story I'll tell is when I became chair of the Committee for Infection Prevention at the Southern Arizona VA, I had come back from the SHE meeting in 2009 when antimicrobial stewardship was first being promulgated. And I came back and talked to our chief of pharmacy and said, we need to have a committee. And we did that. We developed a stewardship committee and we got stakeholders, but we couldn't do much more. Why not? Because we didn't have full institutional buy-in. At the VA, institutional buy-in comes from central office, and they control FTE. So it was a couple years before we actually got an infectious disease pharmacist, a stewardship pharmacist. But you can still start the process and be ready and do the education. And you can ask questions in your facility to see where you are. So the first question to ask is, are urine cultures ordered routinely in your facility? Are they being ordered for hospital admission, emergency department visits, preoperative non-urological surgery evaluations, clinical conditions not associated with UTIs, or for change in odor or appearance of the urine? Those are easy to ask and to assess. Is there a rule to reflex to completing a urine culture only when the urinalysis is abnormal? That's again you can ask. Or are people just able to order a urine culture, period? And if you haven't done that, are there any rules regarding when a urinalysis and urine culture should be obtained? Do you have a rule for a clinical examination with documentation prior to starting antibiotics? That's a question that can be asked. And is there documentation about how urine samples are collected, uh, both for clean catch and for catheterized specimens? Do you know the rates of testing for asymptomatic bacteria in your facility? And do you know the rates of antibiotic treatment for asymptomatic bacteria in your facility? So these are all worth asking, even if you don't yet have the ability to affect those. So in summary, urine culture should never be ordered routinely. A clinical examination with documentation should be required prior to obtaining a urine sample and before starting empiric antibiotics for a positive urine culture. Urine samples should always be properly collected for both non-catheterized and catheterized patients. A urine culture should only be ordered and interpreted when appropriate signs and symptoms are present and the urinalysis is abnormal. And diagnostic stewardship is a mechanism to obtain these goals, but demonstration projects are needed to determine barriers, feasibility, and cost of this approach. So with that, I am done with the formal part of this lecture.